You're welcome, Cathryn.
Good morning. Firstly, thanks to the organisation for giving me the opportunity to speak. In my enthusiasm to get the word out, I think I have a lot of slides, so I hope you'll pardon me, I'll fly through them very quickly. Community Intervention Team, what is it? It's a community nurse-led team, otherwise known as CIT. It has the capacity to deliver specific clinical interventions to patients in their own home or in a clinic setting in the community, delivering interventions that previously wouldn't have been available at home, and preventing hospital admission or facilitating early discharge from hospital. The main thing is that we must not duplicate existing community services. So we must not duplicate the public health nursing services. Rather, we work in partnership with them very closely in order to enhance patient care. So I suppose I'm going way back now to the declaration, the Alma-Ata Declaration of the World Health Organization 1978. Any public health nurses in the audience will be very familiar with this. It's really the essence of primary health care, about bringing health care as close as possible to where people live and work. So what's different about the CIT? It's a 365-day service, unlike the public health nursing service, so it's there every day of the year. It's there for 12 hours every day, from 8 in the morning until 8:30 at night. Service provision is anything from 72 hours to 14 days. Some patients only need the service for 24 hours. Our OPAT, which is outpatient antimicrobial therapy, so that's any patient receiving intravenous therapy at home, they can get the service for 6 weeks, sometimes a little bit longer, depending on their condition. The clinical interventions that are being delivered previously would have required hospital admission, and I'll go through those in a moment. The service has a rapid response element, which is fantastic, and I suppose it's, the fact it's there 7 days, and the fact you've all those hours every day to deliver care, you can respond to patients more efficiently. And, sometimes we can respond to patients in an hour. If they have a blocked catheter or a dislodged catheter, you'll do your utmost really just to keep somebody at home. We have that flexibility as well of service delivery. I suppose the fact the clinic is open at 8 in the morning, so some of our patients have returned to work. It might suit them to come in at 8 in the morning. It might suit them to come at 7 o'clock in the evening. It might suit them to have the service at the weekends. The really good thing is we don't have to ask that dreaded question, do you have a medical card? The service is open to everybody. Once you're over 16 years of age, there's universal eligibility, once you fulfil the criteria. We're not network defined or primary healthcare team defined. We move across all the networks in within our geographical area. And anybody over 16 years of age can meet, once you meet the criteria. So the model we have in the Midwest is we have a regional service. We're extremely lucky. We have the only regional community intervention team service in the country. We have a defined geographical area across Clare, Limerick and Tipperary. The main hub is in Limerick. We have 2 satellite teams then in Ennis and Neenah. They would originally have been set up at the time of reconfiguration a few years ago in the Midwest. The population we serve is 380,000. In 2017, with demand really on the service, we put a satellite team in West Limerick to cover back to the Kerry border, and now we have a satellite team in Thurles. In 2018, hopefully we'll have a team in West Clare, because that's a particularly isolated area as well, and I suppose with reconfiguration, a lot of the patients living in West Clare now have to travel. They have to bypass Ennis Hospital and travel into Limerick. And we're a HSE model, which is slightly different from some of the newer community intervention team services that have been set up. They're with the private provider, but we are a unique HSE model, and our governance comes from the Director of Public Health Nursing. We're a nurse-led team, but we have a skill mix. We have healthcare assistants on our team, and they're absolutely vital to the service. That's the map of our coverage area. Really, to be honest, we cover all of Clare, Limerick and North Tipperary. The red areas would be the outlying areas that we struggle to cover at times, with resources, but generally we can work around it, through offering patients maybe clinic appointments or that. These are all the services. These are your clinical interventions that are available at home. So you have intravenous antimicrobial therapy, and that's under the governance of the ID consultant in University Hospital Limerick. Diabetic care, blood glucose monitoring, might be newly diagnosed diabetics coming out of hospital. Subcutaneous fluids that would mainly be used by the GPs who refer older people, under hospital avoidance, who may need 24 hours of subcutaneous fluids to keep them at home. Intravenous viral therapy. We do a lot lot of central line care, and we do central line care for patients who reside in our area but who also attend other hospitals. So you might be getting your treatment in Dublin, Cork, Galway. It doesn't matter. Once you're a patient in our area, we can offer you that service. Venipuncture and cannulation would mainly be done for oncology patients. They can come into our clinic and have their chemotherapy bloods done beforehand, which means they don't have to go into the hospital, wait around for the results, and they can get a call then from the oncology nurse telling them, yes, you're suitable for chemotherapy, so come in tomorrow. So that's a very efficient service, and it works very well for those patients. Urethral suprapubic catheterization. We set up a pathway with the urology department in University Hospital Limerick a few years ago, where we now manage a cohort of male patients that have indwelling catheters. So we manage them really in totality, in that they're booked in for their changes. If they block or dislodge, or if they have any problem in the meantime, they no longer have to ring an ambulance. They ring us, and we sort it just to keep them out of A&E. Suprapubic replacement of suprapubic catheterizations as well. Nurse monitoring following fractures and falls, people that are coming out of hospital. Palliative end-of-life care. We work very closely with the home care team in Milford, and as you know, particularly maybe if a patient is coming out from hospital, could be on a Friday, and the home care team hasn't the capacity to get into them until Monday, we can manage that patient over the weekend in conjunction with the GP and give them their drugs for end-of-life comfort measures. Respiratory care, O2 saturation monitoring, older person support in general. We do a lot of older person support, and I'm really with the people who spoke about the privatisation of social care earlier on, because really social care has now become a business model, and the patient is very definitely not in the centre of that. And I see the gaps in that service, and we pick up a lot on that in supporting older people who just can't avail of home help. We disconnect all the chemotherapy pumps in the area. We do medication management as well. All of our patients have to come under one of these three categories. Hospital avoidance, so they would be your oncology patients that are coming into us for their pre-chemo bloods or their disconnections. Primary care team refer, the other hospital avoidance would be your male catheters. Primary care team referrals then would be from the GP or the public health nurse. And self-referrals then, we can only accept self-referrals from patients who are already on our, that we have a file on them and we've had a previous referral, and these might be patients with chronic illnesses like multiple sclerosis, motor neuron disease, things like that, so that if they have a problem and we can sort it, they will contact us. Admission avoidance then, these are patients that have presented to the hospital but we're trying to prevent them being admitted into a bed. So we get cellulitis maybe from the emergency department, and also we get patients from the medical assessment unit and the surgical assessment unit. Early supported discharge then, these are patients that are inpatients and that we're trying to get home. We're trying to shave a few days off their stay in hospital. The OPAT patients would be the biggest group in that, and I suppose they're very easy to quantify because they need 6 weeks of therapy, so we know categorically if they couldn't go home, they had to remain in hospital for 6 weeks. So that's 6 weeks of bed days saved. So it's very much like a step-down service, really. We bridge the gap a lot, particularly in the patients awaiting home help and home care packages. We have healthcare assistants, and we can put them into the home for 2 weeks and give that patient a service for 2 weeks. We did a pilot with one of the wards recently, because we had just observed there was a lot of patients were going down the road of transitional funding, maybe not at their own request, but in order to get them out of hospital in a timely manner. And some of these patients wanted to go home, so we were able to put our healthcare assistant in twice a day for 2 weeks. And at the end of that 2 weeks, I suppose the beauty of it was you really got a good picture of how much support that person needed. So maybe the hospital had referred them for 10 hours of home help or 20 hours of home help or whatever. We could, give a more accurate reflection, having looked after them for 2 weeks. Our mission statement, we must ensure that the standard of care delivered is always equal to or greater than acute hospital care. Our referrals, just to give a breakdown, Clare, Limerick and Tipperary. Limerick would be by far, I suppose, population-based, the busiest service. The dark green are interventions and the others are referrals. So I suppose on average we'd have about 7,000 referrals last year. The service is growing year on year, and 14,500 interventions, so it's busy. It's like a virtual ward, that's how we would describe it. It's like a virtual ward really, but it's spread over 3 counties, and on any given day you have 40 to 60 patients receiving services in that ward. What supports us? Our governance structure under the umbrella of public health nursing, infection control, quality and patient safety, health and safety, and our own department policies, procedures and guidelines. We have a national CIT governance group, and I suppose we're extremely lucky. We have commitment from senior management in CHO3 in developing our service. And I suppose the most important thing is we have a group of very dedicated, competent nurses and healthcare assistants working in a supportive environment and ensuring safe, quality patient care. Why it works, the 3 C's: communication, communication, communication. If anyone told me I'd have needed a degree in communication skills when I took on this job, because it's all about getting the word out there, really, and making sure the service is known about. Co-location, we are co-located near the hospital, so we spend a lot of our time in and out of the hospital. We meet the patients before they go home and try and make it as seamless as possible. And confidence in the service, really. I think if people have referred and they have a good experience, they will continue to refer. It's very collaborative and integrative. Integrated care is the buzzword at the moment. We're very integrated with the acute hospital in the area. Primary care teams, community nursing units, palliative care services, home care package and home health coordinators. We work very closely with the discharge coordinators in UHL, and they're actually co-located with us in our building, and that works very well. GP cooperatives, the out of hours, we get referrals from Shannon Dock, who'd be our out of hours GP cooperative, and the local injury units, and they would be Ennis and Nina. How do we measure the service? We measure quality really through clinical audits. We do clinical audits in our own service, and we also do patient satisfaction. And I suppose it's very reassuring just to get a sense from patients of what the service means to them. So that really motivates us all, you know. The future of the service, I suppose we would very much like, if we had allied health professionals on the team, we would like, you know, access to occupational therapy and physiotherapy, maybe looking at rehabilitating people at home that are waiting to go to rehab units, and I suppose delayed discharges in the acute hospitals. We really need the service to be embedded in the clinical care programmes, and we will be very much part of the integrated care programme that's being rolled out in the Midwest at the moment. Information technology, we absolutely need electronic referrals, and nurses need tablets to do their, you know, documentation while they're on the go. And especially now with the data protection changes that are coming this month, it's very relevant. Role development, we would like to expand the role of the nurses within the service, particularly the healthcare assistants as well. I suppose we have come up against a barrier in that there's no regulatory body for the healthcare assistants to report to, unlike nurses. But we have done some upskilling within our own service, and that has been very effective, and a nurse prescriber would be a great advantage on the team. We would like specific metrics. We have metrics in various areas, but I suppose specific metrics to measure the effectiveness of the service and the value for money, because we know it's value for money, but it's just trying to, you know, trying to measure that really accurately. And finally, I suppose the major determinant of our success really will be the quality of the care that is provided and not the place of delivery. Thank you.